Hello and welcome to our webinar today. Today's topic is Mini Guide to SBIRT, an overview of SBIRT and resources. And our webinar today is presented by the Big SBIRT Initiative, the National SBIRT ATTC, and NORC at the University of Chicago. I'm Tracy McPherson, and I'm going to be your presenter today, and I'll also be your moderator. And we'll have time for questions at the end, so I would encourage folks to, as we're going through the presentation, feel free to use your chat function and your questions pane to be able to communicate with us. I'll moderate the questions at the end. I would also encourage you that if there are things that come up that we don't get to, that you maybe you submit a question for and we don't have time to get to it, or there's just other things that you think about as you're with us today that you'd like more information on, you can feel free to email me, and I'll remind you at the end of the presentation too of how to contact me so that we can get you some information and resources that you can use in implementing SBIRT. So I direct the Brief Intervention Group with my colleague, Dr. Eric Goplerud, and I'm also one of the principal investigators on a couple of initiatives that you're going to be learning about today. One of those is our partnership with the National SBIRT ATTC, and I'm the Training and Technical Assistance Lead for NORC on that project, and working with IRETA, who administers the National SBIRT ATTC funded by SAMHSA. I'm also lead the BIG initiative, so there are lots of things, resources that we're going to talk about today. If there's anything that comes up that has the BIG initiative around it, websites, materials, information, the BIG initiative is housed under NORC, where I am. And I would be the primary contact person for that. There are going to be a lot of resources today that are also coming from the National SBIRT ATTC, and I'll provide a link to their website. Certainly you're welcome, if you have questions about those materials, to direct them to me as well, or to reach out to them directly. Also, we have a new website, which is I'll show you later, but we're launching kind of a one portal landing page for most of our initiatives. They're all sort of funneling through the sbirteducation.com website. So we have lots and lots of information up there, lots of resources, and we're now trying to pull them together so it's even easier for you to find what you're looking for. So I would encourage you to explore that site and to come back to it as you see additional materials and things loaded up there. So this webinar is actually kicking off our 2016 series, and I'm really excited about this because we haven't done an overview of SBIRT and resources in a long time. Sometimes we think everybody's already heard about SBIRT, people have heard the acronym, but what I really realized in traveling the country and doing technical assistance is there are many people who are new to SBIRT, are really learning about SBIRT. They know what the acronym is, sort of, maybe, but don't know what the resources are. And so we really thought that kicking off this series with an overview of some of the materials around education and implementation and training and evaluation that are freely available to you that you probably have no idea that even exist. And so I'm really excited to share some of these things that we've worked on and with our partners. And then coming up later in the series this year, we're going to be talking about integrating adolescent SBIRT education into interprofessional curriculum, and also within nursing and social work education specifically. We also have some other hot topics coming up around preventing prescription drug abuse and prescribing guidelines, particularly focusing on skills for nurses and other healthcare professionals. So we're not focusing on the docs. They pay a lot of attention to the docs, but this is really about nurses and other health professionals. And then intimate partner violence and SBIRT, and one of the few models out there, the WINGS intervention model, that has been used and has been tested in randomized controlled trials. So we're really excited to have that topic, and we'll also have some topics around tobacco SBIRT, which is like revisiting the past, but there's sort of a renewed interest in tobacco SBIRT, and also gambling SBIRT. And then how do you use motivational interviewing throughout the SBIRT model, wherever you're applying it to, or with whatever behavioral health condition? Like, how do you really try to hone those skills and teach others, educate others around motivational interviewing? So I really hope that you'll enjoy the presentation today and that you'll join us in the future. And all of our webinars will be posted at the hospital sbirt.webs.com website, and there's a dedicated page to the webinars. So you can access the materials, the PowerPoints today, the materials and resources that we have loaded to the website are those for which I didn't provide a link. So many of the resources have a link on the slide so you can actively link to the material, but there's some things that we've developed and that you're not going to have access to. So we've gone ahead and loaded those to the website right under the PowerPoints, and so you can access those at any time. They'll stay up there into infinity. After the webinar, we will actually record this and archive it and put it up on our website, make it freely available. We would encourage you and your colleagues, if you want to revisit it or have other colleagues take advantage of the free education, to go through it. It's going to be, again, up there as long as possible, usually years. So I think this information will probably stand the test of time because it's already stood the test of time. And so I think it'll be a good resource for you to share with your colleagues. For this webinar, we will not be offering continuing education credits, but we will offer a certificate of completion. Sometimes that can be used, you know, in the processes that you have to submit for on an annual basis. And so we thought at least providing a certificate of completion, verifying that you were participating with us would be nice to have. And so you'll be able to access those on the website. You'll be able to request one of those, and it will be disseminated to you electronically. So if you're not familiar with GoToWebinar and you aren't really familiar with the sort of the question panes and the chat boxes, usually they appear up on the right, and you can see there are certain categories like questions and chat and handouts. If you would actually expand the questions box, you can actually type your question in there. And so those will get stored until the end, and then I will go through and moderate them and try to get to as many of them as possible. You can also use the chat pane to chat with myself or our technical facilitator behind the scenes, Misty Story, if you have any questions. And this is our technical facilitator. And I would say if you are having any difficulties with accessing any of the materials on the web or any of the PowerPoints, certainly Misty will help you with that behind the scenes. Okay, so part one of this mini guide and overview is just to review, provide a snapshot of SBIRT and still where we are in our thinking about SBIRT and provide a high-level overview. And it's a nice introduction because we have some on-demand learnings for you that we'll point you to later that go into the depth of the screening, which is the S, or the BI, which is the brief intervention, and the RT, referral to treatment. We have several three-part series, multiple-part series on-demand learnings that go into the depth. But this will give you a kind of an overview of what those on-demand learnings cover, and just to kind of refresh on where we are. So SBIRT is still commonly defined by SAMHSA and others as a comprehensive integrated public health approach to the delivery of early intervention and treatment services for people with substance use disorders and those at risk for developing them. My hope is that the definition gets modified over time and really focuses on those that are at risk for developing them. Because for me, and I think for many people in this space, that's really the sweet spot of screening and brief intervention. What SBIRT does offer, though, is something for every level of risk through the entire continuum, from being at low risk to being at risk to being at high risk. And that's the beauty of SBIRT. But I'm really hoping that the definition will sort of grow and emphasize more of that piece. I feel it's kind of tacked on. So I'm seeing some new definitions out there, but they still are very flavorful of this. But I think we all agree that the strength in SBIRT is really the last part of this, about really identifying those who are at risk and understanding what level of risk at which they are. So substance use is a public health problem, and that seems obvious now as we've come along in our thinking. But early in SBIRT, we were not thinking of substance use that way. The definition reflected a public health approach and dialogue around how we talk about substance use. But historically, it's been thought of as a moral issue, a criminal justice issue, many different ways of thinking about it. But we've come a long way in really thinking of risky substance use as a public health problem. It does impact the public. It impacts the health and of our clients and patients as we work with and the families. It has a lot of negative impacts. These are things that you see in the work that you do already. If you're working in settings where you see diabetes or another physical health condition that's exacerbated by risky substance use, it will affect the effectiveness of medication, something we haven't talked a lot about, but it really is something where you're finding a lot of contraindications around medication. So we haven't really talked about before. You get the little warning labels over on the pill vial, but nobody reads it, and people don't talk about the risks of taking a medication with alcohol use. So risky alcohol use, though, is also associated with excess costs and hospital stays, things I'm sure if you're working in an emergency department you see or in a hospital setting, and injuries and accidents. And most people don't think about it, but actually of the $223 billion that CDC estimates is the cost of risky substance use, about 70% can be accounted for in productivity outcomes, work-related absenteeism and presenteeism, and of course for our young people and our college-age folks, problems in school. Specifically for adolescents, there's like a whole other host of negative possible consequences that we see that are a little different than adults. But schools and relationship problems, legal problems, sexual risk-taking, and of course substance use impacts the family and relationships. And we're hearing a lot, of course, about overdose and suicide. And so it is a public health problem, and I think SBIRT is one approach of many in responding to this public health concern. And I think we're all trying to use this approach to really move these things and reduce these risks and to not have these be the most profound impacts that we see in the work we do every day. So the components of SBIRT, regardless of what model, we'll talk about some of the models, but regardless of what model you are wedded to or you're considering, the components of SBIRT are the same. And they don't really vary by substance or by behavioral health concern. It all starts with screening, and the screening is really about identification. We really never did screening. We waited till people had an issue, a health issue or a mental health issue or a substance issue. We wait till they come and see us and talk to us and show up after there's already major problems and consequences. But what we're really thinking about now is how do we get ahead of that? How do we do early identification? How do we identify risk before someone meets diagnostic criteria or is experiencing dependent symptoms and harmful consequences? We use screening to identify risky alcohol use, tobacco use, drug use, including prescription medication misuse, and depression. We're now seeing expanded to intimate partner violence and anxiety and gambling. So I think this definition, or these components, the way they're described, has really expanded in the recent years as we've seen more growth in this area. The beauty of screening is that it helps us understand the level of risk. Instead of ignoring when people don't have a diagnostic disorder, we typically have ignored people who don't meet criteria. We don't do anything for them. We sort of wait until there's a problem. What we're doing is we're identifying that level of risk prior to them ever moving into that end of severity continuum. So you're identifying folks at low risk, at moderate risk. Sometimes it's called moderate to moderate high or high to severe. There are different ways that different screening tools describe it. But the bottom line is you're getting at different levels or continuum of risk. And that the level of intervention for someone at low risk is a light touch. It's raising awareness of risk. It's reinforcing staying at low risk to try to keep people low. So even if you're low, you would get a brief intervention in the SBIRT, in this SBIRT model. For those that are at moderate risk, moderate to high risk, you would employ brief intervention that would have a little bit more intensity. You wouldn't want to apply a light touch to someone who has more risk. It uses motivational interviewing strategies. You don't have to be an MI guru. You don't have to be an expert in motivational interviewing and all skills, but having some proficiency to facilitate a motivational brief intervention, to have a discussion about someone's risk, feedback about risk, their use, the pros and cons of use, thinking about how to engage them in a conversation about making a change, facilitating ideas about change or change talk. It's about engaging in a dialogue to help the patient or the client come up with their own reasons of why they might change. So in brief intervention, uses levels of intensity, and of course brief intervention at a higher level of intensity is called brief treatment. And it's providing multiple brief interventions over time for a longer period of time, whereas a brief intervention, maybe 1, 2, 3 brief interventions, a brief treatment would be a pattern of brief interventions or sustained sessions over time. Both of them employ motivational interviewing. Sometimes people are very skilled in cognitive behavioral strategies, cognitive behavioral therapy, and perhaps when there are conditions or situations where someone may be at moderate risk for alcohol but high risk for tobacco, there may be medications that are used around tobacco cessation. So it really is trying to use and employ all the tools that we'll talk about a brief intervention that are common to the models, and helping raise not only awareness and knowledge about how to reduce risk, but then facilitating, if needed, assistance to seek additional services or to seek a treatment such as tobacco cessation. The other level of risk, which in this particular model is called high, could potentially get all of the things I just described at low, moderate, and high. What you find in practice is some folks say, okay, well, if it's high risk, we're just going to refer them. I'm not sure if that's the best model. We don't really know if that's necessarily the best model because RT is the weakest link of the SBIRT model. But you can use brief intervention in a high-risk situation in 2 ways. You can engage them in a conversation about reducing risk or cutting back or abstaining, or you could use the opportunity to have a motivational conversation around taking steps to seek additional level of care. So in this particular, the RT part, it's a problematic for me because I wish RT was called referral and treatment, not referral to treatment, because referral to me is one thing and providing treatment is a very different thing that we're seeing more and more in integrated care become part of mainstream healthcare. And I hope that will continue to grow with medication-assisted treatment, integrated care kinds of models. So, but this does give you a sense that this is still sort of where we are with the components of the model. And when there are more complex conditions, whether it's medical or physical, medical, physical, behavioral, mental, when there's complex conditions and complex cases, we really do want to try to provide a referral to treatment, but with best practice, meaning that you want to employ warm handoff, or warm transfer, and linkage to care. Referral to treatment shouldn't be a piece of paper. It should be a delivery, delivering someone to the next level of care, the next person, whatever it is. It needs to be about handing someone off in a way so we don't lose them, because we're not very good at this, and we lose people. And I think that's the weakest link in a place where we have a lot of opportunity. But the message really is that no matter what the behavioral health or substance use condition within this loop in which we apply SBIRT, the model is very similar, regardless of the specific approach that you actually decide that you want to use. And we'll talk about those approaches. Here's another way of thinking about the continuum. We used to only think about the people at abstinent or low risk with the green circle on the left, and we would historically wait until someone showed up with a substance use disorder potentially, or they've already met criteria. Now the sweet spot is really is the yellow. It's the binge use. We don't often use abuse anymore, and this reflects our changes in language, excessive use, heavy use, at-risk use, problematic use, binge use. All of these kinds of things are the risky at-risk users. And so what SBIRT really allows us to do, as we were talking about those different levels of brief intervention, is apply the right level of touch to each of these levels, low, moderate, and high risk. Here's another way to think of it. We often talk about the drinker's pyramid. There's also one around using the DAS screener and substance use. But this is just a nice visual to kind of get a sense of, in the general population of healthy adults, about 75% of the population is at low or no risk. And so no intervention may be necessary, or it might be a light touch with screening score feedback and just supporting the positive nature of making that decision not to engage in risky drinking, sort of confirming and praising people for that kind of behavior. And then in the middle, where again, there's another way of representing that sweet spot of SBIRT, is the 20%. It may be 20, it may be 23, 25, or if you're in an ED, it may be 40. But in the general population, it's somewhere between 20 and 25% of the population who are engaging in at-risk use, hazardous, harmful, symptomatic use, and where brief intervention or brief treatment may be the most appropriate. And then at the very top of the pyramid, that very small percentage where we have historically focused all of our efforts is the place where certainly the referral to treatment, the warm handoff to treatment, or a higher level of care and brief intervention to motivate individuals to connect with care. This is just another representation. And so what you can use this for, too, in implementation is if you're in the general population, you would expect that if you use universal screening, that about 75% of your population is going to score at low or no risk. And those folks are going to have very light touch. And what that translates into is not a lot of staff time, because that's the biggest concern, is when we're implementing something like this, and if you're implementing it for multiple substances or conditions, how much labor, staff time, resources is it going to take? The 20%, the sweet spot, 20, 25%, that's approximately the proportion of the population for a general healthy population that would score at risk. And so those would need some level of brief intervention, not necessarily brief treatment, multiple sessions over time, although they might if they're in that higher, on the cusp of perhaps going into high risk. That may be where brief treatment may be most appropriate. But it gives you a sense of how many brief interventions we might expect to do. So some of this is to really help you understand the continuum, but to really think about from an operations point of view and resource needs, how does this translate into actual on the ground? So the aims of SBIRT reflect that full continuum. The aims are to increase early identification of those that are at risk for substance use problems, really build the awareness and educate around U.S. guidelines for low-risk drinking and risk-associated substance use, which we don't typically do until after someone has already developed a concern, and motivate those at risk to reduce unhealthy, risky use and adopt more health-promoting behavior, and motivate individuals to seek additional services, healthcare services, it may be treatment, and to access care. How do we motivate and increase the access to care for those who are at risk? And then for those at the highest risk, delivering them to more intensive healthcare services. And then pretty much the summative statement is really to foster a continuum of care from integrating prevention. This could be it could end up being a prevention approach for those who are at no risk or low risk, preventing them from moving up to a higher level of risk. It's certainly an intervention, and it also can foster delivering people to other. All right. Misty, can you advance the slide for me? Thank you. So we're not going to go into the depths and breadths of the evidence around SBIRT, but what I want to give you is a snapshot of sort of where we are. Many of you may have seen this. We haven't changed honestly, that much since this was developed. It is under review, I'm told, but still predominantly the literature on alcohol use and tobacco use is the strongest, and certainly has consensus that that should be it's an effective practice that should be delivered routinely. Around illicit drug use, marijuana use, which is actually legal in some states, it's really mixed. There's growing evidence, inconsistent, varies by population, and we have a lot more work to do. But there are clinical trials going on, and there will be more studies, and we need to be doing more work in that area. The same thing goes with some of the other behavioral health areas around depression and anxiety. There is SBIRT has been applied in depression and has been used. I would say I'm less familiar and have heard less about the use of it around anxiety disorders and trauma, but my understanding is people are doing the work, but we're still not that much further in updating this table than we were a few years ago. I do hope that we will continue to do the work, and we'll be able to sort out, whether it is effective with marijuana or prescription medication misuse, but perhaps not other substances. And we need to really sort that and really see for substances and for specific populations what's really working. And again, just going to point you to some research that's publicly available for those who don't have access to research articles. Here's a publication that came out of SAMHSA and some of the thought leaders around screening and brief intervention. So I point you to that because they do review some of the literature around hospitals, EDs, and primary care. Also want to just summarize for you, and if you're interested in any of these, you can let me know. I'm sure I have copies I could send to you for educational purposes. We've got to the point with adults that we can do meta-analysis, we can do literature reviews. We used to cite just an emergency department or a trauma center study or a primary care study. We have enough evidence to do studies across studies, analyze data across multiple studies, and to do literature reviews of a very vast body of work. And so I've provided some different examples of sort of what some of the meta-analysis have seen, and have showed reductions in substance use using brief interventions that use a motivational interviewing approach, and have had some other positive outcomes, social outcomes and academic outcomes, and also around injuries and DUI. So there's lots of different outcomes that we've been looking at. Some of the things I talked about earlier about some of the things that substance use are associated with. Those are things that are being studied, and I think we're finally getting to a point where across a number of those domains we have enough to really look at and determine how much, for whom, in what setting really works. We still need to do a lot more, even though we've already done a lot so far. But the literature has convinced the U.S. Preventative Services Task Force to recommend screening and brief intervention for adults over the age of 18, and that includes the screening and the brief intervention to engage them in a motivational brief counseling intervention to reduce their risk. The Institute of Medicine, though, put out statements in 1990 about endorsing screening and brief intervention. So my point here is that really, we have identified 26 years ago that there were suitable methods in place to be deployed. However, we're still early in translating research to practice, and with the wonderful support of SAMHSA and other federal agencies, HRSA and others that have really put some attention to this, we are now seeing it more translated into practice. But it's just an example of how it takes a very long time to move a field, and our government agencies and our private sector organizations have really done a lot to really move this and to study it in a variety of settings. But adolescent SBIRT's a little different. We are not as far along, but we're far along enough to do a meta-analysis, but there's a lot more work to be done. I think there's consensus that this is an area of growth and an area of real promise with adolescents. There's probably more consensus around this is a promising area around adolescents than there is adults, because people are very divided about whether there's still really strong enough evidence around adults. But for adolescents, I think there's consensus that we have a lot more work to do. But it is promising that we've seen reductions in alcohol use and reductions in marijuana use and some other outcomes. And I hope we continue to explore and research this, and that our federal agencies and colleagues that we work with continue to invest in this area, because young people, if we can work with them early and intervene early, we think it has much more promise in preventing a later substance use problem or other consequences they may experience throughout the course of their development. Unfortunately, there's just still not enough studies. There's insufficient evidence. Doesn't mean that the evidence, there isn't something promising in there, but it means we just really don't have enough rigorous studies to really conclude. And so the U.S. Preventative Services Task Force has not been able to make a recommendation based on the evidence they've been able to pull from the scientific literature. That has not stopped folks from recommending it, and those that look at the literature feel that it is promising and have made formal guidelines and statements about the use of it with adolescents. And so APA, the American Academy of Pediatrics, and AMA, and numerous other government agencies have really promoted the use for pediatricians and other healthcare providers. They're working with children and adolescents to do screening for substance use and brief intervention routinely, using motivational interviewing techniques. And to be, I think what is really important about this statement is that to be familiar with the network of treatment providers, be familiar with those who can provide services to adolescents, to be able to deliver them to care. Not just stop at the SBI, but how do we deliver adolescents to the next level of care? These are just some of your other federal agencies and professional associations who have either come out with formal guidelines, made formal statements, have implementation manuals, have guidance around on how to implement it in various settings, and have really backed implementing screening and brief intervention, some for adults, some for adolescents, some for both. But as you can see, there's enough that people feel that there's a promise to keep doing this, keep doing the work with young people, and to keep pursuing the science around screening and brief intervention, and to study it. Somewhat like building an airplane while you're flying it. But we do have to build it, we have to fly it, and we need to study it and test it. And that's what we're doing, I think, to some degree. So the disappointing news is that although there's all these guidelines and recommendations, and there's plenty of implementation manuals and tons of people to help us implement this and train people to do it, we're not doing it. Health professionals don't often ask. Few pediatricians routinely ask, despite the guidelines. Young people in the young adult age range, who are most likely to exceed those daily and weekly guidelines, they're less likely to report that they've been asked by a health professional about their drinking. And then 1 in 6 adults, very few adults, including binge drinkers, report they've ever had a conversation about alcohol with a health professional. I personally can't remember in my lifetime any health provider ever asking me about alcohol use or drug use. Only recently at a primary care clinic, someone asked me about tobacco and said, "You don't smoke, do you? Have you ever smoked?" in that kind of tone. And I thought, as much as we're doing this, and I think one day when I walk into every doctor's office and they're asking me about these things, I'll feel like I've made a difference. But I think we're all trying to move this needle, and I think people want to move this needle. It's figuring out how to help them do it, how to really ask in a way that doesn't disrupt processes and flow, and really that they can have the tools to ask these things in a way that integrates into their system. Because if you're snapping something on or making it an extra thing, we're not going to make any dents in asking people. So these are some of the places where I see SBIRT integrated, and if you have other places that you've seen, maybe you recognize that you've worked in these places, you've worked with your colleagues in these places, you may not be aware that SBIRT is even happening in these places. So some of these may be a surprise, others may be no-brainers. Primary care and trauma and ED is where a lot of SBIRT work started, so that makes sense. But as you look at some of these other settings in colleges and school-based settings, FQHCs, employee assistance programs, juvenile justice, peer assistance programs, dental clinics, HIV, faith-based. These are newer. I mean, we did have some effort around colleges a decade ago, and there seems to be more now focused on adolescents in college and in school-based settings. Certainly, there's a lot more attention happening now. But some of these other places are really, really new. If there's something, a place where you see SBIRT happening that's not on this list, I welcome you to, put it in the chat box or the question pane and ask me to update this slide. But this is where we're seeing it, and this is where it can be integrated. So I just wanted to give you kind of a snapshot of the model and how it applies across substance use and behavioral health conditions, where we sort of still are with the literature, at least in my understanding of the state of the literature and what I feel is I hear in consensus in these circles. And to give you a sense of, sort of who's endorsing it and who's providing the guidance and the support around trying to make this really happen in practice. In part 2, I wanted to provide a brief overview of some validated screening tools to assess alcohol and other substance use risk. And some of these you've heard of, some of these you may not have. Some have been out, but nobody's talking about them. Others are sort of coming out, and the science, I think, will be published this year. So one of the things that, regardless of what screening tool you use that asks about alcohol, standard best practice is to employ the standard drink chart. So when you're screening someone and asking about quantity and frequency, which you would do in, say, an AUDIT C, which I'll show you, you're asking about consumption. And when you're doing screening, you want to make sure that the person that you're screening and is answering the questions understands what you mean by a drink, because believe it or not, people have very different ideas of what a drink is. Some people drink Mai Tais or Long Island iced tea or a mojito and don't really know that that's not one drink. It's possibly 1.5 drinks, 2 drinks, 3 drinks, 3.5 drinks. And so it's important at least to have some common understanding of what a standard drink is. And so you present the standard drink chart. You can do it as a visual aid. You can actually print this and laminate it. It makes a great pocket card. Or you could just describe it verbally to them. So before you ask them the questions, you would, what I mean by a standard drink is. You don't have to describe all of them, but you could pick up a 12-ounce can of beer, a 5-ounce glass of wine, a little more than a half a cup, or 1.5 ounces of vodka or gin. But it's important because it's going to affect how people respond and the accuracy of your screening if you're talking about consumption. So I highly encourage you make that some sort of visual or laminated card that people can readily use when they're practicing it. So here are some of the validated screening tools for adolescents and young adults. And the CRAFFT, many people have heard of the CRAFFT, but don't really know what it is. It's very easy to use. And it's really a mnemonic, an acronym that asks about these experiences in their life, not about quantity and frequency of use, but the things that affect, have they been in a car with someone or have ever driven a car while using substances? Do they relax, use substances to relax, or when they're alone or forget, and so on? That's more common and something people are a little bit more familiar with. And it is kind of people think of it often as a gold standard tool. The S2BI, or Screening to Brief Intervention, is relatively new. This one's a little different in that it does look at frequency of use, and I'll give you a screenshot of that. And this is out of Boston Children's Hospital and Sharon Levy's group. And they've been studying this and have developed a really nice manual, the Adolescent SBIRT Toolkit, that uses the S2BI and talks about how to interpret it and how to employ brief interventions for people at different levels of risk. And so this is really new, and I hope folks will, take a look at it and see what's coming out. It's one that's available electronically as an electronic screening tool. It's been validated in that delivery modality. It can be also used in an in-person interview. Then the NIAAA Youth SBIRT Guide, people have heard of it, not really sure what the screening part is, and it actually is a screening based on age. So see, all these are very different in the approach they take to screening, but they've all been validated. The GAIN, a short screen, is even different. It looks at internalizing and externalizing disorders or risk for those disorders, and it's developed by Chestnut Health Systems. And it's like a whole suite and family of information around the GAIN tool. And so you can very quickly, you can Google GAIN and you get everything you could possibly want to know. It's one of the few of these that aren't sort of just publicly available. You do have to request it and sign something saying you're using it. But all the rest of these you can publicly, they're publicly available and you can use. But I see the gain a lot in NIH clinical trials and other research, and I am seeing it more in practice than I was 5 years ago. So I want to mention it because it is a validated, well-respected tool, and a lot of people don't know about it. And then the audit. You may think, why are you saying the audit when we're talking about adolescents? Well, what we found in the literature, and many people don't know it or don't talk about it and are unsure about it, is that the audit can be used with young adults and adolescents. And if you dig into the literature, it's the cutoffs that are different. The cutoffs are much different for an adult than they are for an adolescent. Although when you get to 18, a young adult, they do use the same cutoff as an adult. So I point that out because what I'm finding is if people could use one screening tool and not have to use multiple screening tools for different age groups, it would streamline their process, is what they tell me. Right now, people use the audit often and then the CRAFFT separately for the adolescents and the audit for adults. But if we can use it, and I think we should be doing more research in this area, is to see what are really the cutoffs. John Knight has done work in this area, and Dr. Chung has done work in this area, but there are a few out there, and I think we should be exploring this to see if we can use one tool. It might help with the uptake of actual screening young people. The validated tools for adults, the audit, very common. It focuses on alcohol use, quantity, frequency, dependence symptoms, picks up on dependent symptoms and harmful consequences. The DAS, the drug abuse screening test, doesn't ask about specific substances, but asks about drug use in general. And then the instructions defines what they mean by drug use. So you're answering questions about any of those drugs. So you don't really know what they're responding to. You just know there's general drug use. The NIDA quick screen I'll show you, which people don't seem to know much about, is very quick, and it does cross a couple of different substances which people like. There's the NIDA modified assist, and then the full assist, which is a little longer and really does drill down into more specific substances, very specific substances over different spans, quantity and frequency of use over different periods of time in their life. And then another one that people don't know much about is the NIDA, American Psychiatric Association emerging measures. And I'll show you those because it seems to be getting a lot of interest when I talk about it because it uses a completely different time frame. Most of these are assessing over the past year. Sometimes some of these will do something a little bit more recent, but nothing as recent as 2 weeks. And so I find people are really favoring that, and I'll show you that. And then you've probably heard of the single question alcohol screen and the single question drug screen and the single question tobacco screen, supported by NIH and CDC, really one-item screeners. And then the GAIN can also be used with adults. One of the things I want to show you that you haven't seen, maybe you have seen these, but not in this particular way, is one of the things I'm asked to do often is to help people select brief screening tools that they can put together in a cohesive way to make a brief behavioral screen. So I work with different sites, and they want to use the first 3 questions of the audit, which is the Audit C, and then they want to use the first 2 questions of the PHQ-2, and then they want to use the NIDA quick screen, and they want to put that all into one screening tool and call it a brief behavioral screen. The great thing is it doesn't invalidate any of the instruments. They're all standalone as pre-screeners or full screens. And so I've put a copy up on the web for you so that you can take a look, see if it might work for you in your processes. Sometimes you want to use this as the first opportunity in a clinical intake or some other kind of triage process to implement the brief screen, to decide whether you even want to implement one of those full screens like the audit or the DAS or the assist. And so this is becoming more and more popular, I find, as I'm out in the field, because people really do want to screen across substances and they want to screen across behavioral health conditions, but they don't want 100 questions to do it. And so I would encourage you to think about how might you put together your own brief behavioral screen, or if you'd like us to create a combination for you, I can certainly switch something out and put something together for you. You can just email me. One of them that we created for a group out in Nebraska, we call the Healthy Lifestyle Screen, and they like that better than substance use and emotional health screen. They like it better than behavioral health screen. But it is really a brief behavioral health screen, and includes also questions about safety, about intimate partner violence, about other kinds of questions around anxiety and trauma. So, as you think about what you want to do, it's nice to know you have options, that you don't have to employ a full screen on every single behavioral health condition. There is a way to identify risk and determine really whether you need to take a next step and employ a full screening tool. So here is a picture of the audit. It's very easy to find on the web. It's on our website. It's 10 items, focuses just on alcohol, very easy to administer, and it's kind of a tried and true. And but the wonderful thing about it that it offers, that a tool like the CAGE, if you've ever heard of that, is that you score it, and it gives you a score that you can place along a continuum in certain zones or risk bands. That's the beauty to me of having a screening tool that leads to decision making. And so the audit tool will give you scores and bands of 0 to 7, 8 to 15, 16 to 19, 20 to 40 to determine the level of risk: low risk, at risk, high risk. Sometimes you see this defined as low risk, moderate risk, high risk. So sometimes there are variations on how people define it. But it goes back to the components of the model I described, and giving the right touch at the right level, so you're not applying a hammer touch when you need a light touch, and a light touch when you need something a little bit more intensive. And it really does help define what goes into the brief intervention. Now, that sounds easy, except for depending on which model you pick, it sort of defines what the elements of that brief intervention are, and we'll talk about that. But the beauty of this screen is that it really guides you in determining level of risk and the level of brief intervention. The DAST is also one of those. It focuses on just drug use, and it is 10 items. It's still fairly brief. But you score it, the number of yeses, you create a score, very easy, and then you get these wonderful wristbands to help guide you in deciding, well, do I deliver simple advice as my brief intervention and education, or do I really do something more intensive, employing motivational interviewing skills and employing their thoughts about their screening risk and pros and cons of use and their readiness to change? What level am I going to employ when I'm having a conversation? The tools that I have in my toolbox. So again, a nice map to tell you where should guide you in the kind of services that you provide or recommend. This is the NIDA quick screen I was telling you about that many people don't really know much about or are aware of. And we provided a downloadable copy of the NIDA quick screen and the manual that goes with it, because for some reason people haven't been able to find it. But it's very easy, and it taps across alcohol, tobacco, prescription drugs for non-medical reasons, and illegal drugs. And what I'm finding in practice is that some just want to use this. And if they're at risk, they're going to provide a brief intervention. Others say, I'm going to use this as a pre-screen. I really like that it taps across dimensions. And if there's something that's positive, then I'll employ an audit, or I'll employ an assist, or a NIDA modified assist, or some other tool. So I wanted to bring that to your attention because it seems like an overlooked tool that could be really useful. This is one that I'm finding people are not aware of at all. It's the NIDA Modified Assist APA Emerging Measure 2-week version. I don't know if they're actually going to what they're going to end up calling it, but it's essentially what people have been looking for is a 2-week version. What in the past 2 weeks, what has use been in 2 weeks? Not in the last year, but could they use this as a measure of change over time, reflecting asking questions about use in the last 2 weeks, because I've heard that, with the 1 year time frame, and you want to administer it at multiple time points, 3 months, 6 months later, there's always been the recommendation not to change the time frame in the question. So you're each time asking about past year, but you're only 3 months out of the last time you met with that person. And I was talking to one of the NIDA clinical trials folks about using this as not only as a screening measure, but a change over time measure. They strongly encouraged that this could be used in that way, and people have been looking for that. And it's very easy to administer. And the literature and the research that's being published is supposed to come out in 2016. I don't know if anything has been released prior to that, but just within the last couple of months I was told it was coming. So I point you to this because it does get to specific substances, but you're not administering the full assist or another measure that really what we're finding is they might be terrific measures, but the folks in actually using them don't like them. They're too intensive, they're too confusing, there are too many pieces of paper. There are a lot of reasons why. So I'd like to draw your attention to that and explore that, and we've provided a copy of that also on the website. And so here's a snapshot of the CRAFFT. This one looks a little different than some of the versions you've probably seen. This is sometimes used as a pocket card, and they just ask the CRAFFT questions. This is used with adolescents and young adults under the age of 21. And with the CRAFFT, it has a nice provider manual. It tells you everything about the CRAFFT, how to use it, how to interpret it, what goes into the brief intervention. We have a copy of that on our website as well. The other version of the CRAFFT actually has some intro questions, where there's a couple of questions in the beginning that determines whether they move to the remaining 6 questions. I've seen both used. I don't know that one is necessarily more valid than the other, but certainly people like this with adolescents because it's very easy to use. And you can get a sense here that it's asking about alcohol and drugs in these particular contexts and using them in these particular contexts. You don't really know about quantity or frequency or which substances, but it is a validated tool to help you understand risk and where an adolescent is on the continuum of risk. And here's a snapshot of the S2BI. People like this too because it's very simple. It will ask about tobacco, so you do get the specific substance, the tobacco, alcohol, and marijuana use. And it does ask about frequency. And so you ask these questions, and if there's any response other than never to the first 3, you would then ask about prescription medication use for reasons not prescribed to them, which we call non-medical use, or an illegal substance like marijuana in some states, inhalants, and herbs and synthetic drugs. This is online. It's an electronically available version. I provided a link. And this also, I was telling you, has a wonderful manual available to talk about how to provide a brief intervention if you're going to use the S2BI tool. And then the NIAAA Use Guide. This one totally different in the way it screens, but a wonderful resource if you'd like to screen by age range and looking at elementary, middle, and high school ranges. And you really want to take a different approach from quantity and frequency, and you want to explore really from their use, but also from their friends' use. This is a tool that may really resonate with you. And it does ask about personal frequency if the adolescent does drink. And it does provide nice sort of risk bands. It will classify folks, young people, by age and by quantity based on whether they're in a lower risk, they call it lower risk, moderate risk, or higher risk. So you can see that there's a lot of variation in what they use to determine risk, whether it's age or consumption or experiences, and the way they create the risk bands are very, very different, and what they call them are very different, which creates a lot of confusion, I think, sometimes when people are choosing, do I use this tool in these ranges or do I use this other tool? And they're all validated. So I don't know that one is better than the other, but if you're using a validated approach, that's the most important thing. And so in sum, really, the beauty of the tools that I've reviewed is that they do help you make decisions. And you don't have to guess. It takes the guesswork out of it, but it does still need clinical judgment. You have to use your clinical judgment to inform these decisions. I would encourage you, and I found this very useful in working with people to implement programs and screening, is to develop your own decision tree and identify the tools that you're going to use, identify what the scores are and the ranges so that the folks using the tools will know what level of risk that person would be classified in based on those scores. And then have at the lower level, the level of brief intervention. What goes into the brief intervention for those levels of risk? It's a decision tree. It's a nice aid that people don't have to remember off the top of their head, oh, 16 to 19 on the audit gets brief intervention and it might get brief treatment. Having those visual aids will help enhance fidelity to the model. And it has just a nice visual way of mapping out the way you're going to implement it. And you can also check in with staff and others to make sure and revisit that this is really what's happening on the ground. So this is an example available from the Pacific Southwest ATTC, but you could create your own. I think it's a really nice tool and what we found very helpful in the implementation science of it. So that provides a little bit of overview of some of the existing and emerging measures and just some thoughts about the utility of those. Now I'm going to move to part 3, which is the models of SBIRT, and give you an overview of the models and some of the common core elements. You know, what I find is that sometimes people have just heard of a model. So they say, okay, we're going to use B&I. We're going to use frames. We're going to use 5As. We're going to use basics because they've heard of it. Not necessarily for any other reason. Maybe that they have a trainer who knows how to train on B&I but not on frames. Or they really like it because it makes sense to them. Sometimes it just resonates with them. The steps are easy to follow. It varies a lot between what appeals to different people and what models they would actually use. But across all the models, a brief intervention is a brief intervention. It really is a time-limited, individual, non-confrontational, and I would say non-judgmental way of interacting with someone to provide health counseling session. And health counseling, I think everyone can relate to, whether you're in the medical or behavioral health or another field. You might counsel people around health concerns. It may not apply this definition if you are in criminal justice or in another setting, but you see very different definitions depending on the setting. But in general, it could be a health coaching, it could be a consultation, but it really is time-limited, individual, non-confrontational opportunity to have a motivational dialogue with an individual to help move them along with their readiness to change, to identify opportunities for change, and to consider making a change. Across the models, most of the goals are pretty much the same: to educate on the safe levels of substance use and what the low-risk guidelines are, increase the awareness of the consequences of substance use, motivating towards changing substance use behavior or behavior related to substance use, like driving behind the wheel, and assisting individuals in making their own choices and facilitating them to identify their own motivation for change and to their own desire, their ability, their readiness, their need to change, and helping to draw that out in them. Let them come up with the reasons for change to reduce the risk around substance use problems. The goals generally apply to all the models. So here are some of the models that you may have heard. The brief negotiated interview, the B&I, which has been used a lot in hospital settings and emergency settings. Frames, sometimes people I've seen add another A or another R or another M, but frames is just another model. It's another acronym for the components of a brief intervention. Flow, I don't know if you're familiar with that, but that's been used in hospitals. But these have been used everywhere. I've seen B&I used in community and flow used in EAP, 5As. You've seen it a lot around tobacco. You've seen it in college settings. We're seeing that, in a variety of settings with other substances other than tobacco. And then basics, which typically I've only really seen mostly with the young adult college age population. But these are different models that people gravitate to for a variety of reasons. And sometimes it may be that there's this really nice, convenient checklist and a nice training and implementation tool that they can really use to implement screening brief intervention. They can use as a fidelity and quality monitoring tool or a feedback tool. there's really, I mean, if you're using a model and it's a good model and you're trying to employ fidelity and quality in the delivery of the model, no one really would say that one of these is better than the other. But it's good to use a model to help guide the implementation. So here is a snapshot of the BNI Art Institute's BNI model, and people like it because it has steps. Step 1, engagement. Step 2, pros and cons. Step 3, feedback. Step 4, readiness ruler. Step 5, negotiate an action plan. Step 6, summarize and think. And this varies a little bit if you're looking at the adolescent version. So there's the adult algorithm, and then there's the BNI adolescent algorithm. But essentially, it looks the same, and it kind of feels the same. The dialogue is different. The elements are much the same. So you're building rapport, you're exploring pros and cons, you're using your motivational interviewing skills, your reflective listening and open-ended questions, you're asking permission, you're using your readiness rulers, your importance and confidence rulers, trying to support change talk and encourage change talk through your motivational interviewing skills, using your ORs and your darn C skills for those who use these skills, and providing education and supporting people and affirming people. But what you notice is I'm using some words that aren't specifically listed as an element, but they're common across all these models. It's just sort of what we've labeled them in these models. This really kind of flushes out nicely some of the steps. Some people would say that BNI is often MI light, that you see less MI woven into the BNI model. I argue, or my position is, that you can employ as much MI in this model as you want. If you strictly adhere to the algorithm and you're really relying on just, a lot of that dialogue, maybe there's just a little bit and it's MI light. But I would say you can weave in as much BNI, MI into BNI model as you possibly can. But that probably depends a lot on the context and the length of time that you have. But certainly a strong model and that people very much like. The frames model.
Tracy, it appears we've lost your audio.
Well, that was a nice introduction to how to use our GoToWebinar. So I'm going to talk about the frames model next, and the frames really talks about, again, the same things we heard in the BNI: feedback, responsibility, offering concern and advice, a menu of options, offering empathy, and building self-efficacy. So you get less detail sort of in how it's laid out here. But if you were to dig deeper and you would go to this training material I provided a link to, what you would find is all those elements we were talking about in the BNI, they're called something different, but many of them are employed in the frames model too. They're very common to one another. We just call them something different. The flow model, F for feedback, L for listen and understand, options explored is the O. We slash out the W because we don't do warnings. We don't warn people. The flow model has very similar components. Again, it's just what we call them: listening, reflective listening. That's what we call it in another model. Menu of options, we call that here options explored. Feedback might be called something else in another model, but often it is called feedback. But a lot of the motivational interviewing skills and the elements of the brief intervention are all woven in, but they're just sort of huddled up into either the F and the L and the O. And I'm going to show you what these elements are after I show you this 5A's model. So this 5A's model: ask, advise, assess, assist, arrange. If you dig a little deeper, you'll see it's asking people about their use and providing feedback, advising them about the risks, assessing their readiness to change, assisting them with an action plan, and arranging, which is delivering them to another level of care, providing a warm handoff, referring them. Again, the same language, the same elements, but we just call them something different. So what I've learned over the years in training on these different models and learning about these models and trying to understand how they fit in different contexts and sort of what people like to use in different settings is that at a minimum, most all of them include, for those individuals at risk, using a non-judgmental tone, and that employs motivational interviewing skills, and that is, you know, has central to it the spirit of motivational interviewing, even if it's MI light or it really has the depths and breadths of MI. At the minimum, there's screening score feedback in all the models. There's feedback about the risks and alcohol education or other substance use education, and often some sort of information or resource that's handed to them or pointed to them on an app or the web. And then there's brief advice about cutting back or abstaining. At the minimum, that and closing on good terms is core to all of them. Some go into a lot more detail and flesh things out, but these definitely seem to be core to all of them. As I dug a little deeper into the different models, this is what I came up with. So if I had to create my own model, and we actually do training that's not specific to a model, so that people can decide later what model they want to use. This is how I think of it, that across all of the models, everyone gets screening score feedback regardless of the level of risk. That's across every model. It may be that a site chooses not to employ brief intervention for those at low risk because of staffing or whatever the reason is, but in the model, everyone gets screening score feedback. Establishing rapport, engaging, establishing that rapport with that patient or that client when you're beginning to ask screening questions or you're beginning to engage in a brief intervention conversation, that's central to motivational interviewing and common across all the models. Feedback about risk, central. The risk that you're learning about through the screening or other things that they have, the person has told you about risky behavior, you're providing feedback about risk. And education on low-risk guidelines or safer use, all of that is still very common to all the models. Normative feedback. Normative feedback varies in intensity across the models. It can be a very light normative feedback of how that person compares to their peers or other adolescents, for example, or how does that adult, how does their drinking compare to the general population? So, for example, that pyramid we used earlier that had the 75 at the bottom, you know, saying that, you know, that person is in the 75%, that most people don't drink or use a substance at a risky level, at the same level as that person. So that's what normative feedback is, and that's very light. There are others that go into age-specific, gender-specific, and substance-specific feedback around, let's say, an adolescent who is, you know, in the 11 to 14 age range, talking about marijuana. What is the normative information we have about their peers at that age for that specific substance for that particular gender? And so that really does vary, but it still can be a core component of all of the models. Simple advice and concern in a non-judgmental tone. Non-judgmental tone should be throughout the entire thing, and every model promotes that. The simple advice is interesting because some models, when you, on surface, they look like, okay, you could stop at simple advice and that's it. But I don't know if that's really what they're advising. Maybe at low risk, but certainly simple advice for someone at the moderate to high risk range wouldn't be the case. Although sometimes when you're looking at the model, your interpretation, when I'm out in the field, I hear, well, it looks like simple advice is all I need to give for anybody at risk, but it's not. There are different varying levels of degrees of providing advice and engaging people and enhancing their motivation, and to extend that conversation beyond advice to use your ORs and your readiness rulers and assessing importance and confidence to make a change, the pros and cons of use, and eliciting change statements. Varying depths and breadths, but they all seem to be core. Assisting with an action plan may be called into something else, like a menu of options, But it is assisting with an action plan. In some models, they talk about goal setting. But this really is about helping someone come up with a specific, obtainable, time-limited, measurable step. Not to change their whole life, but to come up with a step. And so all the models seem to have that core to them. Affirming and giving encouragement. We talk a lot about affirmations when we talk about motivational interviewing and employing those skills. In some models, we just talk about giving encouragement or affirming the adolescent or the patient or the client's remarks to you. We call them different things. They're all central. And providing resources. All the materials provide resources. It could be verbal, that it's verbal information about a resource or an educational information. Resources may be more about connecting someone and familiarizing them with the services provided by that particular agency, or it could be a pamphlet or a website or a application, some sort of app or interactive kind of program that provides information around harmful consequences of interactions with alcohol and medications. I mean, they're all different ways they define resources. Some actually define them in terms of what are the resources in your family or in your relationships related to you. And then closing on good terms. All of the models talk about closing on good terms and how do you close that conversation about substance use and moving in the context of your the bigger environment, whether it's some sort of primary care visit or something in a school counseling setting. You're having this conversation in the context of a larger environment, and why that person came in to talk to you may have nothing to do at all with substance use. So how do you integrate and close that conversation and still really prioritize the presenting problems and close on good terms and encouraging people in a future interaction to explore talking with you about alcohol use or substance use again in the future while prioritizing the presenting concern. That's all core. And then asking permission to follow up, like asking permission throughout to do screening or to give feedback. Some of the models actually do suggest asking permission more often, not just at follow-up. But it is core that you want to plant the seed, that you ask permission to follow up the time at which you had the brief intervention, because you want to make sure that you're planting the seed that you will connect and that you have permission to connect. And then providing referral. And this varies all over the map because it is the weakest link, I think, that we have in the model. Is a referral to some is a piece of paper, or here's a website, or here's a book, or whatever it is. But what we do believe, or at least my interpretation, is that the ideal, maybe not ideal, but best practice is trying to link them with someone else, a resource, through a warm transfer or a warm handoff, if at all possible, is the most ideal. Although we understand that all the resources in the world that we need are not out there, that is the recommendation. But sometimes you can't do that, and so sometimes a referral that is limited in scope and can't do that may not happen. But I think there is consensus across the models that you do want to try to connect people to care. We're just not that good at doing it yet. So in sum, whatever model you're interested in, and we have lots of resources available on these different models. So if you need something, you don't find it on our website, you certainly can email me and let me know, and I'd be glad to share something with you. I'm just going to show you some of the resources that are available to you, so you can, if one of these models gravitates to you, you can begin to pull these resources. So this is the brief negotiated interview algorithm. There's one for adults and there's one for adolescents, and you can see it goes through the steps. It actually has the scripting for you. So if you're not familiar with this, we find that tools like this that have scripting, the models that have checklists and algorithms, really people gravitate to because it's a nice educational and training aid. It also helps in facilitating use it actually in a brief intervention and documenting what has actually occurred. So that's one of the resources available to you. It's in the public domain. Here's another resource. it's the flow checklist, and the brief intervention group that I lead, we put this together after working with Chris Dunn and Craig Fields in a training they did for the hospital systems in Washington, D.C. And they talk a lot about the flow model in their trainings, and we ended up adapting what they taught us into a checklist that hospitals, clinics, and we're now finding other even behavioral health settings are using them now, where it used to be mostly in medical. But it goes through each step of the flow. It has areas for you to check off that step has occurred, and it really does give you a sense of how much time it takes to do it. And these are really reflecting of the times it's taken in practice, although I would say if you're using more of the depth and breadth of motivational interviewing, it is going to take longer. But you can see it does employ pros and cons and summarizing and using some of those key skills, but it isn't, it's not the full continuum of skills. But this is a nice resource, and it's available on the website where the PowerPoints are for your download. Here's another version of it where we actually integrated the audit screener. Some of the settings want to use the audit screener, so we put that in there. And we also added areas where people could refuse. So you could document a refusal instead of it appearing as if the practitioner didn't ask the questions. You could actually document the refusal to be able to look at your data and say, okay, well, we have a 10% refusal rate, or this particular person, this practitioner has a 90% refusal rate. So what's happening there? What is it about the quality or the fidelity to the model, or the way it's being presented? What do we have to do to really boost that more people are engaging? So it's not only for documentation, but some of these things are to help really to provide some monitoring of the implementation. And then this is, I have this up on the web too. It's a document that has a description of some of the protocols that are available to you. They're fully scripted out. Some of them just use the audit C. Some of them use just the basic elements of brief intervention, no motivational interviewing skills. Others, like your SBIRT MI-informed audit, that uses the full audit, and it weaves in the motivational interviewing skills into the scripting. Not that every intervention is going to be scripted like this, but it is in a flow of a natural conversation that you often see if you're watching training videos, or you're observing standardized patients, or you're actually seeing it in real practice. This is often how it looks. It may not look like this. I'm not saying it will look like this. You will have lots of variations, but it's a wonderful tool for just getting to know the language, because the most sophisticated practitioners will tell us, we've never been trained to do this. We don't even know what to say. So if you could give us something to, wrap our minds around, and then we practice it, and then you make it your own, then they feel a whole lot more comfortable. So that's really what it's designed to do. And some people continue to use it when they use telephonic work and they have the scripts in front of them. They are using it still routinely, and eventually they get to know it, and they do make it their own. So there are a variety of protocols available to you that are fully scripted, including follow-up, basic follow-up protocols. What would you say if you were going to make a phone call and follow up with somebody? And how do you, what are the steps in that? And this is just a snapshot of one of them where it walks you through how to introduce the screening, what the questions are, and then if the score is negative on the left, this is what you would say, and these are the steps you would take. And then on the right, if it was positive, you would go into a brief intervention, and you would actually be able to interpret the score, know what the elements of the brief intervention are, what goes into it, and then on the next page, you'll actually see it goes further into the conversation, breaking up each step from the audit score feedback, the alcohol education, the normative feedback, and so on, to give you the script to begin to practice and make it your own. And all of these are freely and publicly available through the brief intervention group. And then the pocket cards. This is a wonderful one we use for the National SBIRT ATTC, and so we usually laminate these. We use them in training. We use them in real implementation. It's happening, on the ground in practice settings. It's a really nice visual aid, and it's just a nice tool to help facilitate, talking about a standard drink, the risk levels for both the audit and the DASC, and what are the low-risk guidelines. And then you have this wonderful ruler at the bottom that you can use for readiness, importance, and confidence rulers. That's all of these are in the public domain. Then Oregon SBIRT has these wonderful information reference sheets. I call them pocket guards, but they actually are more like a reference sheet. They have one for adults and adolescents that are really nice, and they're publicly available. And it has some of the same kinds of features around the cutoffs, the different risks associated with unhealthy use of substances. It has a ruler, and it has some other things related to young people, the risks, the developmental risks specific to them. And then there's another pocket card you could laminate for the standard drink chart. And then I'm just going to highlight some additional resources for you available through the SBIRT ATTC and through the BIG initiative. And I put this up here because there are a lot of people and a lot of associations and organizations that have gone into developing these things and making these things available. So we want to acknowledge their contributions to all of this. We have the SBIRT Education website where you can now go in and you can get on-demand learning, you can get case studies and role plays, videos, quality fidelity monitoring tools, and articles and evaluation measures, all freely available to you. They're divided into different topic areas depending on whether you're talking about a specific substance or a specific population, or you're interested in billing and reimbursement. There's just a ton of things in there that are completely available and free to you. And this is just a snapshot that shows you how they're organized and the direct links to those training materials for the hospital materials. And we call it Hospital SBIRT, but honestly, it's not hospitals anymore. It started off just hospitals, and now it's grown to be basically a way to house all of a lot of our materials. So it applies to other things other than hospitals. And then there's another website for you where you can get on-demand learning and on different topics around older adults, and you can even take a 3-part training on screening and brief intervention, all available for free. And then if you want to, we have actually 4 training learner's guides now available. You can get a sneak peek of those, and there are order forms for different types of behavioral health and health professionals and addiction professionals. And then we have a website now that we've launched an initiative with nursing and social work schools, and if you'd like to be a part of our learning collaborative that's really helping them to integrate screening and brief intervention, you're welcome to visit our project website, learn more about it, and join us in our learning collaborative to help these schools implement adolescent curriculum, adolescent SBIRT curriculum into their programs at the associate, the bachelor's, master, and doctoral level. And we just made publicly available for free the guide for the Adolescent SBIRT. You can go here, request a copy, and we'll send you the materials and all the support materials around implementing Adolescent SBIRT, complimentary of the Conrad Hilton Foundation. And then in addition to that, for this project, we're also developing, and we have developed and now launched, online web-based virtual patient, virtual human, virtual client simulation training programs that not only provide education, but they also have competency assessments in it to assess fidelity to the model and the use of motivational interviewing skills to navigate a brief intervention conversation. And those simulations are now available. And that's just a snapshot and a link for you to visit the resources page that have a lot of the materials. That's just kind of a snapshot of the materials, the case studies, and the other materials that you can download, like the CRAFFT. And then the National SBIRT ATTC has their own toolkit, and that'll come up hopefully. Okay, let's see. Has their own toolkit, and they're funded by SAMHSA to provide a whole suite of services around training and technical assistance and on-demand learning and online resources. They have a lot of resources that I hope you will become familiar with. Misty, can you advance the slide? Oh, I found it. Okay, there it is. So there's the toolkit. Again, please take advantage of all the free resources available to you through the National SBIRT ATTC, including an on-demand SBIRT training for adolescents, which is available for the continuing education credits, and a course on SBIRT 101 that actually goes through screening and brief intervention and motivational interviewing. Those are also available to you for free. And of course, take advantage of their library. They have a wonderful library with different implementation tools, different guidelines, different training materials, And then there's now some interactive web-based screening tools that are available online too that assess up to 15 different behavioral health conditions. And if you're interested in that, you can contact Radiant Behavioral about their online screenings. And then, of course, the NIAAA's, their video cases is also still up, and people are using that. I want to make sure people know about that. It's designed for a range of medical professionals, but I think other behavioral health professionals also use it. And then just for your reference later on, some additional websites that I think are really good, and some sources, some like Colorado SBIRT and Oasis and SBIRT Oregon and Yale and BNI. A lot of the places have really good materials that people respect and point us to. So we have just about 6 minutes to wrap up. So I'm going to open it up for questions and Q&A. And while folks are typing in their questions, I'll just remind you about the questions box, and you can type your questions into the questions box. If you are having to, if you're thinking about next steps after the webinar, I just wanted to point you to let you know that the PowerPoints are up. The materials and resources I mentioned are up. The recording will be put up on the web. You can request your certificate of completion, again, at the website. And for the evaluation survey, you're going to see over in the chat box a link to the evaluation survey. So for live participants in this webinar, you can go ahead and link to that survey and complete the brief evaluation form. If you're going to be watching this on demand, we would ask that once you complete the webinar that you go back to the website and complete the evaluation for the on-demand learning. It's really important, these evaluations, to maintaining our funding and providing you the education, the quality education we're able to do for free. So I cannot stress enough how important these evaluation measures are for us. So while you're putting up your questions, I'm going to start pulling a few now. Assuming I can expand this box. Yes, we have several questions that have come in. Let's see. Oh, child protection social worker could be added to the list of places where SBIRT is being integrated. Well, thank you. I appreciate that, and I will do that. So how can I get a copy of this drinking sizes? Well, you can actually, from this PowerPoint, you can actually, if you print it on a regular printer and laminate it, it turns out quite nicely as a pocket card. If you don't have much success with that, if you email me, I can give you several different options, and you can try to print those and make those pocket cards. I've done those at Staples, and they do really print out very nicely. I'd be glad to send you the file. Oh, other areas of screening, intensive in-home for adolescents and mental health support services. That's nice to add as well. And let's see, any other questions? Do you also offer support to Canada in putting together a preliminary screen? Absolutely. Absolutely. I do. I work with a lot of Canadians for a lot of the work I do outside of this particular project. And I'd be glad to do that under any umbrella, even on my own time. I have tools in French and in multiple languages that could be really useful to Canadians and folks working with other populations as well. And let's see. I noticed the S2BI is copyrighted through Children's Hospital. Would that assessment tool be better used for adolescents or for anyone in general? My understanding, it is designed for adolescents, and that can be middle and later adolescents. And that, you know, my understanding is the tool is available. I know there's a copyright on that particular document, but if you contact them and request and explain your purpose, you should be able to work with them to be able to get a copy of it. We've done that and have made that available in the Adolescent SBIRT curriculum, the Learner's Guide. They gave us permission to include that. And so I would just reach out to them if you have any concerns about that. Let's see. Any questions? Do you have any Spanish literature? I have tools available in Spanish, but I don't have the literature necessarily translated. So the scientific literature, I do not know if it's translated in Spanish. It might be, but the tools, I do have a number of tools in Spanish. The drinking sizes. Oh, so is there a reference to the form of binge drinking concerning different drinking sizes? For example, people that use watermelons or other kinds of drinks. And yes, you can go to NIAAA's calculator, cocktail calculator. They have lots of calculators that will calculate the amount of alcohol in a variety of unusual drinks, the cost of and the cost of the alcohol, which sometimes young people are surprised at how much it costs, but it will calculate the amount in the drink. And so we've come close to the end of our time, and what I'll try to do is go through some of your questions. Most of them are comments or other kinds of just general comments about things that would be nice for them to have. Certainly anything that you want a copy of that is not on the website, or you just want to email me directly to get it, you are more than welcome to. All right, well, I think for now I'm going to say thank you to everyone for your attention and for joining us. And again, I cannot stress enough the importance of our evaluation tool. That is really important to us, and it's a nice way of saying thank you to complete it for us. We thank you for your participation, and we really do hope that you'll join us for these future webinars. And if you have suggestions on topics that would be really of interest to you, we're always willing and interested to hear what your thoughts are and what would make a nice topic for this webinar series. All right. And so if you have any additional questions, if you're interested in getting some technical assistance from me, you can reach out to me by email. I'll be glad to have a technical assistance telephone conversation with you or have an email exchange. And thank you again for your time, and please let us know how we can assist you as you are training and implementing and evaluating your programs. So I wish everyone a great day. Thanks so much for joining us.